Okay, picture this. You're on scene. Major trauma. Your patient definitely has signs of a head injury. Maybe a fall, could be a car wreck. But assessing them is tricky. They're clearly intoxicated. So as an EMS professional, you've got maybe seconds to decide. Is that slurred speech, the confusion? Is it the alcohol? Or is it something much worse, like a brain bleed starting?
That really is the absolute crux of the problem in the field, isn't it? And the big danger, clinically speaking, is this idea of just deciding to sober up the patient, attributing really critical neurological signs just to the alcohol.
Right, and then maybe dismissing the need for specialized trauma care.
Exactly. And that delay, well, it can be catastrophic.
So for this deep dive, we're jumping right into that exact problem. We're going to unpack a really relevant study. It's a multi-center one by Lokerman and colleagues, published in 2023. Their goal basically was to figure out how suspected alcohol intoxication, that key phrase, suspected intoxication influences how well EMS crews identify severe head injuries, SHI, out in the field.
Yeah, and it gives us a fantastic window into actual practice. They looked at data from 19,206 trauma patients, all 16 or older, transported by ambulance in the central Netherlands region over 3 years, 2015 to 2017. It's a really solid data set, lets you see the real signals through all the noise.
Okay, let's get into their methods first. How do they define a severe head injury in SHI?
They used the standard definition, the abbreviated injury scale, or AIS, a score of 3 or more in the head region. So we're talking serious stuff. Intracranial hemorrhages, skull fractures, the kind of injuries where time is absolutely critical.
Got it. And the main tool EMS uses in the field for checking neurological status?
That's the Glasgow Coma Scale, the GCS. It's, the standard metric. It drives a huge amount of the decision-making right there on scene.
Okay, so you've got this standard tool, the GCS, but the study pretty quickly showed just how tough SHI is to spot anyway. Out of those, over 19,000 patients, only 623 were actually diagnosed with an SHI later at the hospital. That's about 3.2%.
A very small percentage, yeah. But obviously a critically important group to identify correctly.
And this is where we hit what seems like the study's most crucial baseline finding. The GCS seems to have a massive blind spot. It really highlights where most of these severe head injuries get missed before the hospital.
It really does. And the numbers are quite stark.
Okay, lay them on us.
So when patients had an obviously low GCS, meaning less than 13, suggesting clear impairment, EMS actually recognized the SHI in 76.2% of those cases, which, sounds pretty good when the signs are really obvious.
Okay, seems reasonable. But what about the other group?
Well, that's where it gets really concerning. For patients who seemed relatively okay, a GCS of 13 or higher, their severe head injuries were only recognized 25.0% of the time, just 1 in 4.
Wow. Wait, say that again? Only 25%?
25%, yeah. So think about that. 3/4 of the SHI patients who don't look critically injured based on GCS alone. They're walking away, initially at least, with a life-threatening injury that wasn't spotted right away by EMS.
That GCS blind spot. That's exactly where the alcohol issue becomes so dangerous, isn't it? That's where the pressure to just assume it's the booze, to sober them up, must be highest.
Precisely. And we know alcohol complicates assessments enormously. The sources confirm it's involved in, 10 to 18% of all trauma cases? And it can shoot way up, like 51%, specifically in head injury patients.
Clinically, it mimics the injury site.
Oh, absolutely. It's a master mimic. Alcohol can cause decreased consciousness, slurred speech, vomiting, all classic signs that could easily be a brain bleed. So EMS is stuck trying to figure out, is that low GCS score because they had too much to drink, or is it because there's bleeding inside their skull? A really tough spot.
Okay, so let's zero in on that intoxicated subgroup. The study identified 1,944 patients suspected of intoxication, which is about 10% of the total group. What do they look like demographically?
Yeah, they were definitely different from the non-intoxicated patients. Significantly younger. Median age was around 47 compared to over 63 for the non-intoxicated group.
Okay, younger.
Yeah.
Anything else?
And predominantly male. About 71% of that intoxicated group were men.
Right. So younger, mostly male. Now, the big question the researchers wanted to tackle was, forget just correlation, is alcohol itself an independent risk factor for having a severe head injury?
And the answer was a clear yes. Absolutely. The data showed pretty definitively. Patients who EMS suspected were intoxicated had a significantly higher chance of actually having an SHI compared to the patients who weren't suspected of being intoxicated.
And they put a number on that increased risk, didn't they?
They did. The adjusted odds ratio was 1.42, which, statistically speaking, is a strong finding. It basically means suspected intoxication boosts the odds of having an SHI by over 40%, even after accounting for other factors.
40%, that's huge. That's a massive red flag that EMS just can't afford to ignore.
It really is. And they checked this too. This held up even when they looked at specific ways people got injured, like traffic accidents or falls. The alcohol itself seems to be the risk multiplier here.
Okay, so we've established alcohol means higher risk. Logically, you'd think that would make the diagnosis harder, right? More confusion, more missed injuries.
That's what you'd expect, intuitively. But here's where it gets really interesting, maybe even surprising. Overall, the study found that suspicion of alcohol intoxication didn't seem to significantly mess up the pre-hospital recognition accuracy.
Wait, really? How can that be?
Well, the ability to correctly identify SHI was actually slightly higher, though probably not significantly different in a clinical sense. It was 45.3% in the intoxicated patients versus 40.2% in the non-intoxicated ones. So accuracy didn't plummet like you might think.
Okay, I'm trying to wrap my head around that. If alcohol confuses the picture, why isn't the diagnostic rate worse for those patients?
So the researchers offered a really neat explanation for this. They called it a kind of dual effect. On one hand, yes, intoxication makes spotting the SHI harder because the symptoms overlap, like the reduced GCS score or the confusion. It muddies the water. But on the other hand, that same suspicion of alcohol seems to trigger more caution among the EMS crews. They know alcohol is tricky, they know it complicates things, so they might actually maintain a higher level of suspicion because of the alcohol.
Ah, so the increased difficulty is sort of balanced out by increased vigilance.
Potentially, yeah. It's like having a tougher puzzle, but because you know the stakes are so high, you're maybe double-checking everything more carefully. That's the theory, at least.
That makes sense. It's a complex interplay.
Yeah.
Okay, so let's talk practical impact. Triage and care. Where did these patients actually end up?
And this is where it really matters for patient outcomes, right? The transport destination. Because where you go first determines the kind of specialized care you can get immediately.
Exactly. And the study found a really big difference depending on whether EMS recognized the SHI or not.
A huge disparity. When EMS correctly recognized the SHI in the field, those patients were very likely to go straight to a higher level trauma center. 85.9% of them, in fact.
Okay, so recognized SHI high-level center. Makes sense. What about the unrecognized ones?
That's the flip side. If the SHI was unrecognized, if EMS missed it initially, those patients were mostly taken to lower-level trauma centers. 62.8% of them ended up there first.
And that means potential delays, right? Having to be transferred later once the injury is found.
Exactly. Unnecessary delays, inter-hospital transfers, all while a critical brain injury might be worsening. It highlights the real danger of that initial misdiagnosis or misdiagnosis.
Now, bring intoxication back into this picture. Did being intoxicated affect where SHI patients were taken?
It did, slightly. Intoxicated patients who had an SHI were actually transported a bit more often to a higher-level trauma center, 63.2% of them, compared to non-intoxicated SHI patients, where it was 56.1%.
Okay, so that small difference, it kind of supports that idea of heightened caution again, doesn't it? EMS being a bit more wary with the intoxicated group.
It seems to fit that hypothesis, yes. They might be thinking, this is complicated, let's err on the side of caution and go to the major center.
Okay, but hang on. Let's pause here. If alcohol is a risk factor for more severe injury, and missing that injury leads to delays in getting to the right hospital, how on earth did the intoxicated group end up with a lower 30-day mortality rate? The study said 0.4% versus 1.8% for non-intoxicated. That seems completely backwards.
Yeah, that's the big apparent contradiction in the outcome data, isn't it? It definitely jumps out. The study suggests the answer lies back in those demographics we talked about.
The age difference.
Exactly. The intoxicated group was significantly younger overall, so they likely had better baseline health, fewer other medical problems, compared to the generally older, non-intoxicated group. That underlying youth and health might have given them more resilience to the injury itself, effectively masking any negative impact from potential delays in diagnosis or transport. They could just tolerate the hit better.
So the lower mortality might be due to the patient population, not necessarily better triage for that group.
That seems to be the most plausible explanation offered by the study, yeah. It's a confounding factor based on who tends to be in each group.
Okay, that makes more sense. Now, before we wrap up the data, we should mention the main limitation they pointed out.
Right, the reliance on suspicion of intoxication.
Yeah, it wasn't based on blood tests at the scene, obviously.
Yeah.
It was based on the EMS crew's judgment smelling alcohol, the patient's behavior.
Which is a limitation in terms of objective proof, but
Right.
you could argue it actually makes the study more relevant to real-world practice.
How so?
Because clinical suspicion is exactly what EMS crews have to work with in the moment. They don't have lab results out there. They make judgments based on what they see, hear, and smell. So the study reflects the reality of pre-hospital decision-making.
Yeah, it's a fair point. It studies the situation as it actually exists in the field.
Yeah.
Okay, so let's pull this all together. What are the main takeaways for you, the listener, maybe working in emergency medicine or just interested in trauma care?
I think there are two really big ones. First, just reinforcing that severe head injuries are genuinely hard to spot pre-hospitally, especially when the GCS score isn't dramatically low. That GCS 13 group is where the danger zone for missed injuries really lies.
Right. That's the baseline challenge. And the second takeaway?
The second is about the alcohol itself. This study really confirms it. Suspected intoxication is a true independent risk factor. It genuinely increases the likelihood of a severe head injury. So the big message is that suspicion of alcohol should absolutely raise your index of suspicion for SHI, not lower it. Caution is critical.
Exactly. That idea of, oh, they're just drunk, could be incredibly dangerous. The study says the opposite. If you suspect alcohol, you should be more worried about a potential underlying head injury, even if, paradoxically, the overall diagnostic accuracy doesn't seem to tank because of that heightened caution we discussed. So the question this study kind of leaves us hanging with, the provocative thought is, if the GCS alone is often unreliable for predicting severity, especially in that higher range group, what else could we add? What other predictive factors beyond just GCS and intoxication status could we build into pre-hospital protocols to help EMS identify these tricky SHIs more accurately?
That really is the million-dollar question, isn't it? That's the next step for improving outcomes. We need better tools, maybe more objective signs or checklists to help crews make that critical transport decision faster and more accurately, especially when faced with all the uncertainty in the field.
Yeah. It just highlights the incredible pressure and complexity of those real-time decisions, doesn't it?
And
Making life or death calls based sometimes on just a sniff of alcohol or a slightly slurred word. Definitely a lot to think about there. Thanks for diving deep with us today.